Welcome to eMedical Legal Radio, starring leading experts who discuss crucial medical legal issues. With your host, Chris Brigham, MD.
Welcome. I have the pleasure of visiting with my friend and colleague, Steve Feinberg, MD. Steve, to begin, could you share with us who you are and what you do?
Hi, Chris. Good morning. I'm a physiatrist and pain specialist in Palo Alto, where I have a treating and a medical legal practice. I also serve on the faculty and teach at the Stanford Pain Center as an adjunct clinical professor. My treating and medical legal practice is primarily workers' compensation based, but I do a fair number of non-workers' comp civil IME type cases.
And Steve, I know that you're highly regarded in California, and in fact, nationally, for your evaluation skills. And I also understand that recently you performed a virtual independent medical evaluation, actually more than one. I think you performed a number of them. Could you share with us the context, the type of problems you encountered, and how you did the evaluations, including how you obtained the history, whether you had the examinee complete any forms, and how did you perform the physical examination?
Chris, I don't need to tell you that you and I and others have been engaging in telemedicine webinars and teaching due to the COVID-19 crisis. And in my case, we've converted my office 100% to telemedicine during this crisis and during the stay-at-home order in California. I've actually done about a half dozen what in California are called agreed medical evaluations, where both the applicant attorney and the claims examiner or defense attorney, agree for me to perform it. And I've been frankly surprised myself at how easy it was and how much I enjoyed doing them. The injured workers I interviewed were quite happy to be in their home and not to be out during this crisis period. They didn't have to wait to have their cases move forward, and some of them were very anxious to get benefits, and so that helped them. The way we did it was that my staff would contact them ahead of time and made sure they were able and willing to participate, because we do need their agreement. And I'm using Zoom, but as you well know, there are other technologies. The patients need a computer, a tablet, or even their smartphone, and it's a rare patient that doesn't have one. That would be a barrier if they didn't, of course. In some cases, the spouse assisted with holding the device, the phone, if I was trying to get them to walk or to move certain joints in certain positions for the physical portion. Interestingly enough, maybe because I'm less busy now with the stay-at-home order, I actually found myself enjoying spending additional time chatting and obtaining the history. The injured workers seemed quite relaxed about it and accepting. Prior to the evaluation, I had already reviewed the medical records. My historian had taken a preliminary history. So I was able to kind of relax and go over the history and the records with the injured worker, the patient. And I basically told them that I would make some they'd hear me typing a little bit as I added or subtracted and corrected the history that had already been obtained. Each patient was sent several activity of daily living forms. One of them is the MTAP, the Multidimensional Task Ability Profile. And I also have a questionnaire that I've published, an ADL questionnaire. So they sent those back to me, which just added to the verbal information I obtained. Now, the important part, the video physical examination. I was surprised at how much I could do. While limited, sometimes it was all that I needed to actually get to case closure for them. Now in California, we use the 5th edition of the AMA guides, and we're supposed to do a strict rating. And obviously, while you can estimate range of motion over a video, it's not the same thing as a goniometer. Some of my colleagues are actually holding a goniometer up to their screen. Also, there's some new technologies that you've talked about that may help us with that. But things like having someone stand on their heels and toes and do a squat does a good job of checking lower body strength. I haven't quite figured out how to check upper body strength to my satisfaction. I'm thinking of ways to do that, like lifting a gallon of milk or some other object. I actually feel that I'm very capable of very closely getting the range of motion of, say, a neck or a shoulder or low back by visual observation. Admittedly, that doesn't meet the strict AMA guides, but once again, we're in a crisis, and if the concerned parties want to accept my opinions and move to case closure, that's fine. I check straight leg raising in the sitting position. I think that's quite fine. I have the individual brush their limbs in terms of any sensory changes. Not the same as me doing it, but once again, appropriate. Yesterday, I did one of these exams and they had a tape measure and we measured girths, or they measured the girths, I should say, and read them off to me. And I want to give you an example of a case I did where the individual had back surgery a year ago. They had a 1-level laminectomy. They were back to work in a moderate job. They had literally no symptoms of any significance. They were able to come up with their toes and heels to do a squat, negative straight leg raising in the chair, good lumbar motion. And to me, that fell into a lumbar DRE3, probably at the lower level of the range at 10%. And I felt very comfortable. But in my report, I wrote to the attorney and the claims examiner, if my opinion was in contention, then I'll be happy to set up a physical examination in my office as soon as I'm able to do so and the restrictions are lifted. So that's kind of a long-winded answer, but that is the answer.
Steve, thank you. You're innovative and thorough, and you looked at the situation where we are right now and how to make the best of it. I have a number of other questions, but I first want to reflect on some of what you said. Steve, prior to these experiences, I know that you were really skeptical about the ability to perform an adequate evaluation. So it sounds like this was an insight to you that it went so well. Is that correct?
That's true. Yeah, Chris, that's a good point. But I have to tell you that I'm still uncomfortable. I'm older and I've been doing it a certain way for a long time. And I still like to see people face to face. I still like to shake a hand. There's a rapport one develops, in the same office. And frankly, we are supposed to provide a standard AMA guides rating. And maybe this will be okay to help with many cases during this crisis. But I'm going to be one of those people that have to be kicked and dragged to the altar in terms of doing IMEs over telemedicine.
But you're faced with the challenge and the reality, and we need to get case closure. That's something I think everyone desires, that of the injured worker to move on with their life, and the applicant attorney and the defense attorney and the payer, so that we are put in a situation where this needs to be done if we can do that. I also reflect on the history. I've done some reading that often the histories that when we obtain them in a virtual environment, they can be more thorough because we actually have more time, and people sometimes are actually more relaxed when they're doing that in their home than in a medical office. So you were thorough with that. You mentioned the forms. Did you have them mail them back to you, or was that done virtually?
Well, I'm embarrassed to say that I use snail mail, but they should be virtual. Not every injured worker is capable of that, but many are. And I'm just not as sophisticated as you would be. I'm sure you would do it virtually. So I'm learning, and maybe you can even help me with that.
I'd be happy to. We've been working on developing those resources. And, it's interesting that I think most people do have some type of accessible device, the computer, the tablet, or smartphone these days. So it's a small percentage. And there are a percentage where we'll have to problem solve that, or maybe we provide them with a instrument. So a question I have for you, Steve, is, reflecting now on the whole process, and you already dealt with this to a certain degree, but what do you see really went well and what did not?
Well, I think in general it went well. I felt that loss of face-to-face physical contact. I wasn't really satisfied with a video physical examination in terms of my preference of doing a more thorough job. I think, I talked to you and you commented before, we're in a crisis period. Some of these people are going without benefits, waiting for approval. So I think we have a situation which is ever changing, but reasonable to do a telemedicine evaluation. And with leaders such as yourself looking at this, I think we're going to find new ways to examine patients over telemedicine. I think there are lots of scenarios where you don't need a physical examination. I think psychiatrists and psychologists may find that telemedicine is a reasonable way to evaluate people, since they don't tend to do a hands-on physical exam. So those are some of the things that come to mind.
Reflecting on that, I also see that what we're experiencing now because of crisis may continue. We may find some models that work better than what we've had before. That having a virtual access would permit someone to see a specialist like you who may otherwise not be able to travel, because we then don't have the barriers that we have. So we can have access to those who are really the finest in the field. And as you and I see that the quality of evaluations, including QMEs and AMEs, vary widely. And some are not what we want to see. They don't meet the standards. But we perhaps can give access to others who are more skilled, who could take those aspects like the history, which is often the defining issues, depending upon the assessment, is where you really get the information that they can spend the time. But we still have to deal with the barrier of the physical exam. But perhaps we can get some higher quality evaluators doing this, even though we have the challenges with the physical process. Steve, overall, I mean, it sounds like you were satisfied with the evaluations that you've had so far. Is that correct?
I was. I have to tell you, as an older physician, a healthy older physician, I'm very nervous about the virus, and I have risk factors beyond just my age. And this has allowed me to keep working and limit my exposure. I actually have some ideas about limiting the exposure with teleconferencing, even when I go back to physically seeing patients. Would you like me to expand on that?
I would love for you to do that.
So I've worked up a whole scenario with my office where I still do the video conference with the patient, but they come to my office during the virus, and when they're allowed to come, obviously, and they basically let my office know they're in the parking lot, and that they answer some questions like you do at any health clinic today about exposures and temperature, and then have them come into my office and not sit in the waiting room and answer questionnaires and do other things, but rather go directly into the exam room, which has been sterilized. And then that allows me to either have spoken to them ahead of time over video conferencing for the history, but I can also use video conference in my own office with them by having a portable computer in my exam room, complete the history that I may not have completed. And then when I physically go into the office with my gloves on and my PPE and my glasses and my mask, I can do a directed, careful, appropriate physical examination. And rather than spending an hour or two with them, I can probably, in some cases, do an exam in 10 or 15 minutes, sometimes a little longer. That meets the criteria for the AMA guides, and yet my exposure and the exposure of the patient to me and my staff is markedly decreased. So that's kind of what I'm thinking about. I haven't worked it out completely, and would look forward to you, in fact, commenting.
Yes, I think such approach would work well. And I think when they come in the office, after doing a screening to make sure that there's not any suggestion of COVID-19 illness or recent exposure, you could also take their temperature, just part of the screening process. And then you could have others obtain some of the measurements. So you have physical therapists who work with you, could obtain some of the range of motion measurements, for example, and you could verify them when you see them. But I think limiting the time that you and that injured worker are together, at the same time making sure you get the information that you need, that works. And I think that would be reassuring to the injured worker. As an injured worker, I would be concerned about coming into an office in an uncontrolled setting and spending a couple hours with someone. But if it was done thoughtfully and screened, and then I saw the physician who had the appropriate mask and the like, and I came in with the mask. I feel a lot better about this. Well, Steve, what were the biggest challenges in doing your evaluations?
Chris, the biggest challenge for me was just that this was new. It also meant more staff time, at least initially, getting the injured workers familiar with this. My staff may be familiar, but the injured workers aren't, and making them comfortable with that pre-visit with me to save my time. The other problem that I'm seeing is that this is new, and the attorneys for injured workers and the defense attorneys for the insurance companies and the payers, I think, are hesitant. There are some people that really think this is all going to go away quickly. I don't think that's true, but some do. And there's an argument to be made. Why don't we just let a couple of months go by, and yes, everyone will just sit around and wait. I don't think that's a good scenario, but I think at least, let me put it another way, I'm noticing some problems getting these evaluations authorized.
Yep. From my perspective, is the delays are not helpful, particularly for the injured worker. It doesn't permit resolution of the claim and moving on with their lives, and for the other stakeholders. And I don't any of us know really how long we're going to deal with the pandemic, but from at least my perspective, it's not a matter of weeks. This is going to be a matter of months or a matter of years. So we need to really start to adapt how we do an evaluation so that can occur. So you've brought up some of the challenges. Do you have other thoughts on how these could be managed, Steve?
I do. Reflecting back on what you said before, I can imagine a scenario where physician assistants or physical therapists throughout the area, but in the patient's local community, could actually make a home visit or in an office. So I get referrals from all over the West Coast. I can imagine utilizing another doctor's office where there's a physical therapist or a physical therapy clinic, and having the injured worker go to that clinic to do the examination at my direction over video conferencing. That probably wouldn't meet AMA Guide's standards, but in the future, I can see that as a possible scenario. I think I'm going to get better at this, and while I'm kind of old-fashioned and prefer the face-to-face encounter, I think that, as I mentioned, there is a hybrid approach that might be good over the long run. I told you before, I have trouble seeing this in litigious third-party civil IME cases, but there are probably exceptions to that.
And I think in those cases too, again, we need to get case resolution. So if you get the information there, and it depends upon what type of information is needed, because if we're dealing with a AMA Guides rating 5th edition, musculoskeletal, often there is a quantitative data that needs to be obtained. But if it's an issue of causation or apportionment, you probably are not going to find that in the results of your physical examination. Rather you're going to obtain that information from the records and discussion with the patient. So I think the hybrid approach you mentioned too, I think that would work well in when you need to obtain the data. The other thing to mention is that in California, the 5th edition of the AMA Guides is used, whereas in federal cases and many other jurisdictions, the 6th edition is used. And with the 6th edition, it's primarily diagnosis-based impairments, where the physical examination is more of an adjustment factor. It may be more important with some upper extremity disorders, but it tends not to be as important as it is in earlier editions of the guides. So, that would probably be easier for people to do who are using the 6th edition. So do you have other thoughts, Steve, on what type of evaluations would be done well virtually? You already mentioned some, like psychological and psychiatry, but other thoughts on that?
Well, I can give you some real world advice. In California, we have proposed emergency regs, and they're suggesting that for what we call AOE, COE, meaning arising out of employment in the course of employment. So if there's a denied body part, where the injured worker is getting no medical care and no benefits, I pretty much don't need a physical exam necessarily to give that opinion. So there's one. If there's a termination of benefits issue, so the carrier is paying money that they don't want to pay or they're not paying at all, I could be helpful in helping with that. If there are work restrictions, while a physical examination face-to-face is nice, I can probably be of help with that over telemedicine. So there are a few options, and I gave you the example of the lumbar spine surgery. I want to also add, Chris, that in California, we're very different than the other states in that the physician, after doing a standard rating, is tasked with providing the most accurate impairment rating. And I personally feel that I have the skill set to talk to an injured worker and be able to, after reviewing the medical records and seeing what they can do physically, given a determination using some other table, chapter, or method. I'll give you an example. If an injured worker convinces me that they've lost 25% of the use of their upper extremity, let's say from CRPS or from some other problem, then I could describe a 25% loss of capacity, which would multiply times 60%, which is the value for the upper extremity, and come up with a 15% WPI. Once again, I would give the concerned parties the option of waiting, of not accepting that, and opting for a face-to-face physical examination in the near future. So there are some different things I can see.
Yeah, I could see an approach like that working. It really depends upon the specifics of the case, and perhaps you can clarify whether or not a virtual evaluation would work after you review the medical records, so that if someone with straightforward diagnosis is clear, you may be more comfortable with that. But if we have another case where we're questioning the validity or the reliability of the history or findings, and knowing that with range of motion virtually, that we just can see active range of motion, we don't know accurately what passive range of motion may be, that may not work as well. So, Steve, what advice would you like to share with others in performing virtual IMEs, AMEs, QMEs?
Well, I guess first of all is that you really need to make sure that you and your staff are comfortable with the software and the electronics involved. Chris, your webinars are superlative, but I was on one the other night where they couldn't even start it, and then all of a sudden someone flamed out in the middle. So there's that. I frankly would urge everyone to give telemedicine a try. I think it's the future. I think you'll be pleasantly surprised that you can produce a good medical legal product.
And Steve, where can we learn more about the work that you do?
Well, first of all, that's very nice of you, Chris. My first recommendation, frankly, is that the audience listen to some of the great webinars that you have online and are about to do in the next few weeks. I've done a number of telemedicine seminars myself. I'd be happy to give you those links if you want to provide them to the audience.
That would be great. We can share that with this podcast content. So that would be great. Well, Steve, thank you so much for spending some time with us today. Your insights, your experience, I think is extremely valuable and will be useful to the viewers and listeners. So thank you, Steve.
Chris, I want to thank you. Your contribution to all of us is just amazing. So stay well.
You too.
Thanks for listening today, and please return to eMedical Legal Radio. Visit us at emedicallegal.com.